Thank you very much. It's my pleasure to be here, and I would like to thank Topcon for organizing this meeting, and especially organizing it in Paris, and also Rick, because he did the most of the work and the program, and really set up a very good program here. So the next session is going to be vascular diseases, so it's one of the other main area of interest for OCTA. And for beginning that, I just would like to share with you our journey about normal, abnormal retinal capillary in diabetic retinopathy. So here my disclosure for working with companies, but most important, I have some acknowledgements. So everything I'm going to talk about is a teamwork. Here a list of co-authors, but there are others in the department, others like Pascal Massin who taught us about diabetic retinopathy who in a way or another participated. The other point is that I present here our journey and contribution as an example of how OCTA helped us to understand, but I know that many here have published very valuable papers with different opinion or similar opinion, and of course I'm not excluding them, but I'm just sharing with you our personal journey. So since the OCTA appeared and we used it, very quickly there was publication, we and others published about the fact that you can see subabnormality in diabetic retinopathy, and this is different to what you can see with the FA. With FA, you have access to the superficial layers. With OCTA, you have access to different layers and deeper layers, and the images are different, so the informations could be different. So as a student in master, I worked with Michel Pack years ago on the normal and abnormal capillaries. I was curious to understand what's happening there. And at that time, it took us more than 1 year to understand and make some images of the mouse retinal microcirculation, and also to look to the circulation of cells, leukocyte and erythrocyte in the macula of animals. And it was just now available to look to the circulation in humans in a large number in a matter of a few seconds. So the first point was to see if what we see on the OCTA is similar to the classical information that we had, like those published by Shimizu and also other publications. Is what has been published, is what we can see by OCTA, or is there any differences in humans or in information we had? So in the superficial capillaries, we find arteries, veins, capillaries, but this was somehow already available on the FA. But what was not really available was the intermediate and deep capillary plexuses that we looked for, and what we find was that it was quite similar to what we found actually in the publication that we published at that time. It's in the middle, and also to what Michel have found in PICS, Michel Pack, and he published recently about how it's organized. So what we see on the OCTA, there is some degree of interpretation about how the connections are made, especially in the superficial, but it seems to be like in histology, mainly a serial organization with arteries mainly on the surface, veins on the deep, and the intermediate vascular plexus, and maybe some connection on the surface. Some people agree and others they don't, but it's very similar to the discussion we had in histology. So first, in OCTA, the multilayer capillary organization is validated in humans, and it's very similar to what has been published. The second question was that you have capillary occlusion in diabetes, you have edema in diabetes, somehow they could be connected. So we look to the connection between capillary occlusion and cysts in diabetic macular edema. Of course, when you have cysts, you don't see capillaries inside the cyst, that makes sense, and superficial capillary are usually on the surface. But what was more interesting is that when the edema resolved, you don't find back, differently to the discussion we had, you don't find back the capillary in the deep capillary plexus coming back in the area of the cyst. And as Rick said, the edema comes back in the same area later on. So it seems that there is a co-localization of loss of capillaries and appearance of cysts. So if there is a co-localization, you can consider that one can cause the other. That's the first hypothesis. So, okay, CME and capillary dropout colocalized. Let's go to the next step. So the next step is to see, is one of them creating the other? So let's look, if cyst appears in the retina, is it going per se to destroy the capillaries? So we look to the acute pseudophakic cystoid macular edema because this happens in a supposedly normal macula. So cyst appears and then they disappear. Of course, it's a short term, it's more inflammatory than vascular disease, but what we notice is that when you have the edema, there is some decrease in the deep capillary, or at least you detect some decrease, but then once the edema disappears, everything comes to normal. That doesn't exclude that a long-term cyst could destroy capillaries, but at least it's not automatic that as soon as you have cyst, you lost capillary. When cyst disappear, you have your capillary back. So if it's not cyst destroying capillary, could it be that loss of capillary explained appearance of cysts? So we know that if you have capillary occlusion, huge ischemia, you don't have edema. But not always edema, I mean not cystoid edema. But this may not be a proof because you say if there's no perfusion, if there is no arteries, if there is not capillaries perfused, it's normal that you have no fluid. So maybe we have to look to something different. So in a paper we have just submitted, we look to a subgroup of diabetic patients that are young patients that they lose capillary very quickly. So that's what has been called the florid diabetic retinopathy. It's not always used in all countries. In France, we continue to use that. It's patients that very quickly they lose capillary and they go to a proliferative diabetic retinopathy. So we look to these patients. So they lost capillary like 10 times more quickly than others. And what we noticed is that they can lose the deep capillary plexus and even lose vision, but they don't have edema appearing automatically. So it's not cysts that destroy the capillaries, and it's not because you lose your deep capillaries that you have to have cyst and edema. So if it's not one causing the other and the other causing the one, so what could be the next step? So if it's not this, you can imagine that there's a third player. So there is someone else is causing both of them or something else causing both of them. And we, like others, again, I share with you our journey, but others has published as us that there was a correlation with diabetes, macular edema, ganglion cell layer thinning, poor vision in diabetes, and diabetic patients lose cells much before, before sometimes losing any capillaries. So we can imagine that loss of cells could explain loss of capillaries, or the other way, actually. So in glaucoma, it has been published that there is a correlation between loss of capillaries and ganglion cell, and there was a session about that. And we also looked and find some colocalization that we hadn't finished the work, not published, but it has been looked by other, and we will have other information later, I think so. There was some colocalization between loss of cells and loss of capillary. It makes sense. In the body, nothing should be unuseful. If you lose cell, you lose vessels, and you lose vessels, you lose cell. So diabetic retinopathy, for what we can say at least, it's not exclusively a vascular disease. It's not because we have OCTA, and now we can look to the vessels, that we can imagine that everything is explained by occlusion of vessels or circulation of vessels. There are other things, and vessels are here for other things too. By the way, we saw interesting things. We saw that some cysts decorrelate, and we found it in 1/3 of diabetic macular edema. This could overestimate the capillary, and we hypothesized that it could be related to precursor of hard exudate. We haven't published it. We saw it very early, but we haven't published, but there have been very good publications by Amir Kashani. They have seen the same things. They have published it, and with a quite similar hypothesis. And the other way that now we have wild field swept source OCT, we look to the peripheral retina, and this is also a source of understanding. Of course, you can see very beautiful things, but what we looked is at how capillary density changed, for example, after anti-VEGF injection. So you know that it has been said that anti-VEGF could improve the perfusion. So we looked to that. So I will present the result at Macular Society, but just to say, some tips is that we didn't find any reperfusion in the short term, at least. In the long term, it may be the case. So looking for edema and capillary occlusion, we had some miscellaneous information that were also interesting. So to summarize, we think right now, after having different opinion and having testing different opinion, in diabetic retinopathy, the neuronal structure, vascular perfusion, and permeability are altered as an intricate unit. They work together, they are related to each other. So it's very difficult because losing one is colocalized and is ended with losing the others. They are working together and you lose all of them all together, and they seems all be related to glycemic changes or hyperglycemia, we don't know yet. Thank you very much.